But Chris Boneff disagrees. He leads the Oregon chapter of the National Alliance on Mental Illness, which helps about 14,000 Oregonians a year. When I got him on Zoom today to talk about this issue, he had a lot to say about why it's so hard to get people help.
Well, there's two issues going on. Is you have people who are on the streets and have mental illness or substance use disorders, and they've been on the streets for a while. Their acuity is high. Those are folks that represent a real failure in our healthcare system, because before they reach that point, they hit our healthcare system and other community systems probably multiple times, and we did nothing to prevent their deterioration. And so that's one issue. And because we don't do a good job of that and still don't do a good job of that, the number of people at that level of acuity continue to increase, which makes the homeless problem and housing problem even worse. Second issue going on, when someone is at that level of acuity, under the way our civil commitment statutes in Oregon are interpreted by the Oregon Court of Appeals, it's virtually impossible to compel someone to engage in treatment, get them off the street, unless they the danger in how the court interprets danger is really imminent. And so it has to be within that moment. And if that danger isn't showing itself within that absolute moment, then there is no way to compel someone to engage in treatment or get off the streets or be hospitalized or put in residential care.
Okay, so you're saying that it's not like if the person was running out in the freeway the day before, it's now that they've been picked up, they're sitting in front of a judge. If they don't seem like a danger to themselves right at that moment, then there's no way to hold them.
And it's not even, it's rare to get in front of a judge or administrative law judge. So yeah, if somebody's running around on the freeway yesterday and they're not doing it today, then they're not an imminent danger to themselves. If they were running around on the freeway an hour ago, but they're now sitting in front of a clinician in an emergency room saying they're not a danger to themselves, then under the the interpretation of the law, they're not a danger to themselves.
Wow, that just does not seem right.
I mean, you have to think about this. You don't forget to think about this as a matter of also civil liberties. So because the court in our state has a bias towards civil liberties, and when we were able to civilly commit people, to force them into treatment against their will, because they did sort of meet that definition of danger, we treated those people very, very poorly. We violated their civil rights, and the federal government is still involved in Oregon's behavioral health system because we haven't fully rectified that. So we've abused that power in the past. But yes, it seems through court interpretation that a civil commitment statute where you could compel people to engage in treatment, where we might all as a community make the same interpretation that this person is a danger to themselves, maybe a danger to others, under court interpretation, that it's very, very strict as to how you can meet that criteria anymore.
And for that to change, is that an Oregon state law that needs to be written to clarify that?
Yeah, so it will be a statutory change. There's a coalition that has tried to do that the last two full sessions in 2021 and 2023 to add what we call definitions into the statute. So our statute does list as a criteria for being committed danger to self or danger to others, but it doesn't define what does that actually mean. And so when you don't define terms, that leaves it to a court to determine what do those terms actually mean as a matter of law. And over the years, the Court of Appeals has been the final arbiter on what those terms mean, and that has narrowed the criteria to what we talked about. If it's not happening really in the moment that I'm in front of you as a clinician, I don't qualify for a hold.
Wow. Okay. And then we are also getting emails with people saying, well, we just need to build more large institutions because there's no place to put these people, even if they were picked up. Do you agree with that?
Now, large institutions, that's a misnomer or a myth, as if deinstitutionalization in these large institutions would solve a problem, and they don't. The difficulty, again, is twofold. One, you do have a population that we are compelling into treatment right now. They're the same people that you're probably asking me about, only we compel them treatment because they become entangled in the criminal justice system. We arrest them. And because they can't participate in the proceedings against them, we send them to the Oregon State Hospital for restoration. The problem with large institutions is they're very, very expensive. What we really need are three things. We need better prevention services when problems first arise. Healthcare, this can be solved, a lot of it through healthcare and good healthcare, and we need to improve the healthcare system to treat people when problems first arise. The second, yeah.
Okay, well, you had mentioned that before, and I wanted to follow up on that. What are the things that people in healthcare should be doing that would sort of slow this?
Well, when you go to your primary care physician and you articulate a problem for yourself or your child, primary care should be able to meet your needs, make the referrals, have integrated care, bring to bear medications if those are advisable, but also bring all the other treatment services that are necessary. So seeing skilled clinicians like a psychologist or seeing a licensed clinical social worker or others licensed to deliver behavioral health care. In our medical field, we don't have seamless transition from I'm in front of you with a need and you help me find what I need in the behavioral health system. That doesn't really systematically occur. Other issues are, you go to an emergency room right now, and emergency rooms will tell you if you're in a behavioral health crisis, we're the wrong place for you. So we need emergency rooms to actually adapt to deal with all crises, not just medical trauma. And so when we come to an emergency room in a crisis, actually things happen that help us recuperate and get better so we get out of crisis and maintain good wellness. Those are just examples. It really comes down to this. Where problems first arise and where we go to with medical problems are the same places we go to with mental health problems and substance use disorder problems. And those environments need to be able to treat those because those are healthcare conditions.
I think I also hear you saying that if you can treat the problem when it's first arising, it's much easier and probably more successful than if you're years down the road.
Oh, yes. Significantly. Yeah. I mean, all the data show that we're highly, if you treat the problem when it first arises, we're really, really effective. What we don't do is treat the problem when it first arises. And our systems haven't been forced to adapt fast enough to make this a healthcare issue with a healthcare intervention. Then you're talking about people, when you see people who are homeless, who are really severely afflicted by serious mental illness, that you're looking at a decade or more of healthcare failure that has led to the person being in that position. Our ability to intervene then is really minimized because it's hard work. There's not a lot of resources and choices. And that person's ability to reach a recovery baseline is more compromised. So the longer you go untreated, the more damage, permanent damage that can be done to the brain, meaning my recovery may look vastly different. I may never fully recover to the point of where this problem first appeared.
Hopefully that gives you some insight to what we're seeing on our streets. I thought that was fascinating. He said our community also needs more long-term places where patients can stay a month or longer once they get out of the hospital and get stabilized. And he said we need more money. And if you think Measure 110 money will help, he said, it mostly will not, since that money is focused on drug addiction treatment, not treating things like bipolar depression or schizophrenia. Let me know what you think about these issues. Send me an email or give me a call.